We are live.
Hello, good evening, everyone. I welcome you all to the 94th episode of the AIOS ARC PG teaching program. So, this teaching program is a program with a difference because in this we cover topics that are not covered by other PG teaching programs. So, every week we have either a case presentation, short and long, didactic lectures, we discuss an investigative modality, or we have a journal club like we have today. So the journal club is done with the intention of helping the PGs to not only take the journal article at its face value, but also to critically analyze it, see the methodology, and then arrive at your own conclusions whether that research is worth applying in your clinical practice or not. So today we have two young presenters, Dr. Purva Verma and Dr. Ria Utpal Majumdar, who will be presenting their journal articles. We have their mentors, that is Dr. Akansha Raghuvanshi and Dr. Stuti Somani Agarwal, who have very ably tutored these residents. And most important, we have a very astute panel of discussants. So we have with us Dr. Vivek Varkad, who is a consultant in pediatric ophthalmology, strabismus, and neuro-ophthalmology at the LV Prasad Eye Institute, Bhubaneswar. And we have Dr. R. Krishna Prasad, sir, who is a very renowned pediatric ophthalmologist and glaucoma specialist at the M.M. Joshi Eye Institute, Hubli. So thank you so much, Dr. Varkad and Dr. Krishna Prasad, for your presence here this evening. And we're really looking forward to all the inputs and the insights that you're going to give us after the end of the journal presentations. So with that, I invite our first presenter, Dr. Purva Verma. So Dr. Purva is a third-year resident at the Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi. And her mentor is Dr. Akansha Raghuvanshi, who is an assistant professor in the same institute. So over to you, Dr. Purva, and she has a journal article on which will evaluate the surgical outcomes in acute acquired comitant esotropia managed with and without preoperative PRISM adaptation test. So over to you, Dr. Purva. Yeah.
Good evening, everyone. Today, I, Dr. Purva Verma, under the guidance of my mentor, Dr. Akansha Raghuvanshi, would be presenting in today's episode. The study we'll be discussing is a comparative evaluation of surgical outcomes in acute acquired comitant esotropia managed with and without preoperative PRISM adaptation test. This was published in journal Strabismus on 25th April 2025. It was authored by myself, Dr. Purva Verma, Dr. Mitali Khurana, Dr. Vishali Tomar, Dr. Kanchita Pandey, Dr. Subhash Jadeja, and Dr. Paramita Datta. The aim of this study was to compare the surgical outcomes in patients with acute acquired comitant esotropia, which were managed with and without preoperative PRISM adaptation test. The motor outcome was evaluated in terms of the correction of angle of deviation, and the sensory outcome was evaluated in terms of change in the stereopsis. The now talking about acute acquired comitant esotropia, it is a rare type of esotropia which is clinically characterized by acute onset of comitant esotropia, which is either constant or intermittent, is associated with diplopia, has normal ocular motility with a good binocular potential. It can be etiologically classified into three variants: the Swan type, the Burian-Trinchetti type, and the Bilchowski type. The various treatment options which are currently used for AAC are prescription of glasses, prisms, eye patching, botulinum toxin injections, and surgery. The various indications for surgery in acute comitant esotropia is a significant deviation which is stable for at least 6 months, diplopia, and for cosmetic purposes. The surgery can be a unilateral or bilateral medial rectus recession or a unilateral medial rectus recession combined with lateral rectus resection of the same eye. Prism adaptation test, which was introduced in 1970 by Jampolsky. It is an effective method for improving the correction of acute acquired esotropia by revealing the maximum angle of deviation, which may otherwise be masked. So in this study, it was a prospective study with single center based, randomized with parallel group comparative uh, design. The study duration was for 12 months. The sample size was 40, that is 20 in each group test and group control. It was the inclusion criteria in our study was patients aged between 8 to 40 years of age with acute acquired comitant esotropia of all types, a history of onset of more than equal to 3 to 4 months, and a deviation of less than 30 prism diopters. The visual acuity of more than equal to 6 by 12. The exclusion criteria were any history of previous squint surgery or unilateral or bilateral amblyopia. Computerized randomization was done. The 40 patients were randomly allocated into group test or group control. Group test represented patients who underwent preoperative prism adaptation test before surgery, and group control did not undergo preoperative prism adaptation test before surgery. No blinding was done during this study. So here we have tried to summarize the methodology used. Uh, all patients of acute acquired comitant esotropia were screened according to the inclusion criteria and were random computer and were randomized into two groups. Surgery was done in both the groups. In group T, surgery was preceded by prism adaptation test, which was used to determine the surgical target angle. Uh, and these patients were then followed up till 3 months, and uh, post-op analysis was done. Uh, Preoperative evaluation comprised of a detailed history taking, visual acuity assessment, cycloplegic refraction, post which glasses were prescribed for at least 6 to 8 weeks, fundus examination, deviation assessment, for which prism bar cover test was done for distance and for near in all the 9 gazes, and the maximum angle and the largest angle of squint was noted. Stereo acuity evaluation was done using the Titmus fly stereo acuity test for near stereopsis. In group T, the prism par obtained with PVCT was mounted on a trial frame, and prism adaptation test was done for a duration of 1 hour, following which the PVCT was repeated. The surgery was planned according to the maximum prism adapted angle, that is the deviation which was uh, obtained from the initial PVCT and the deviation obtained from the PVCT done after prism adaptation test. Group C patients underwent PVCT alone without any preoperative prism adaptation test, and the surgery was based on the angle of deviation which was measured by the initial PVCT. The surgery done was either a unilateral MR recession alone or in combination with a unilateral lateral rectus dissection. Post-op analysis were done at week 1, week 4, and week 12. A successful motor surgical outcome for distance and near was defined as a post-operative horizontal alignment ranging from plus minus 8 prism diopters of orthophoria. Sensory surgical outcome was considered positive if there was any improvement in stereopsis noted. The statistical analysis was done using the statistics software SPSS version. For stereo acuity, average of the stereopsis value was taken. Normality of each variable was assessed using the Kolmogorov-Smirnov test. Quantitative data was expressed by mean, standard deviation, and median, and was analyzed using the student t-test or the Mann-Whitney U-test. While the pre-post comparison was done using the paired t-test and Wilcoxon's signed rank test. Qualitative data was expressed in percentage, and difference between the proportions was tested using the chi-square test, and p-value was taken of less than 0.05 was taken to be statistically significant. Now the results which were obtained in this study. No statistical difference in the mean age and gender distribution between the two groups was noted. The preoperative data showed baseline PBCT for distance and year for both the groups as comparable. Group T had a statistically significant increase in the deviation after prism adaptation test. The difference in the surgical target angle for group C and group C, and the prism adapted angle for group T was also statistically significant. The mean of the stereopsis in both the groups was comparable, so was the visual acuity and spherical equivalent in both the groups. This is the data which was included in the study. So here we note that at the baseline level, the PBCT for distance as well as near in both the groups is comparable. Post prism adaptation test, in group T, the deviation increased to 36.9 PD, which was statistically significant, and the surgical target angle for both the group hence became statistically significant. Here we also note that during the post-op assessment at week 12, the deviation in both the groups, that is group T and group C, had statistically significant values. Now, looking at the stereopsis assessment, again, it was noted that from baseline to week 12, in both the groups, that is group T and group C, post surgery, there was a significant improvement. And this improvement was much greater for group T. Thus, the intergroup comparison also gave us significant results. Now, through this study, we saw that prism adaptation test led to statistically better surgical outcomes, as no patients in the test group needed any resurgery till post-op period of week 12. In group T, 100% patients achieved primary motor success as opposed to 80% in the control group. These tests were showed similar results as obtained by Prism Adaptation Study Research Group, which was the pioneer study in Prism Adaptation test and in independent studies done by Repka et al. And Otsuki et al. A statistically significant difference in stereopsis between the two groups was also noted at post-op visit week 12. The change in spherical equivalent in both the groups was statistically insignificant. Now here we see in literature there has been limited studies to find an association between prism adaptation test and in the refractive error. Veles et al., Otsuki et al., and Repka et al., they had tried to associate hypermetropic refractive error with prism adaptation test. However, in our study, we could not find any such association. Thus, in conclusion, this study observed that the preoperative prism adaptation test helped patients with acute acquired comitant esotropia with a deviation of less than 30 prism diopters by offering better motor and sensory surgical outcomes. Hence, using preoperative prism adaptation test as an acceptable pre-surgical evaluation method for better motor and sensory optical outcomes is recommended. Coming to the strengths and the limitations of this study. So the strength is that it is one of the first studies which is done in Indian eyes, assessing and comparing the efficacy of the preoperative prism adaptation test in patients of acute acquired comitant esotropia. The randomization, prospective nature, and parallel design gave rise to a superior format for the comparison of sensory, surgical outcomes, and complications. All the examination parameters were done by the same clinician, and all the surgeries were performed by the same surgeon, ensuring uniformity. No patient was dropped out or was lost to follow-up. No patient showed consecutive exotropia at 12-week follow-up, and in no patient till 12-week follow-up, there was a need for resurgery. However, being a single-center study, the results of the study cannot be generalized. Also, patients having more than 30 prism diopters of deviations were not included in this study, which is a major limitation. Long-term follow-up beyond 12 weeks could not be assessed. So, to be sure, of our findings or to support or refute the findings, we would need a longer follow-up. That would be all about this study. Thank you so much.
Thank you, Dr. Purva, for that excellent presentation. So now I invite any comments and insights from our panelists. So Dr. Varkad, invite you for your comments. Dr.
Yes, so
Varkad.
I think there are a lot of things when I read this article. It's a very interesting study for the interest of the resident and fellows when they read these research article for the first time. Then there are a number of things that we should look at. So what Purva has presented is it's just the article, she has put it into the slides. But she should have come up with what is, the her interpretation, her analysis, and how to go about actually, to look at that particular article. So if you allow me, I'll share, the way we in LV Prasad, any article on our JC Wednesdays, we do is, the Mary analysis. Okay, so that's called as a Mary analysis. I'll just share one slide so that everyone would understand, how to actually go about it. Can you see the slides?
Yes.
Yes.
Yeah, so basically the Mary, if you see, you need to look at how was the method that has been used in this particular article. What is the assignment? What is the assessment? Then you have to comment about the result, then the interpretation, and then the extrapolation. So that's the acronym, the MAARIE. So if you ask me for this particular article, you look at this. If I look at in methods, how was the study design? It was the prospective randomized and a parallel design, which is, to me, it looks very good. What was the study population? These are the group of patients who were diagnosed as acute acquired comitant esotropia. However, here the glitch is, the author, they have choose the small to moderate amount of, the AACE, that is less than 30 prism dioptrity. So that doesn't represent, the our clinical spectrum of having mild, moderate, large, or even extra large, the deviations in AACE. So that is one thing which we need to look when you really want to, extrapolate in your own practice. The study purpose was very well defined. The sample size, definitely, this is not at all adequate sample size. If you look at the incidence, especially of AACC in a post-COVID era, so I would say definitely this is a small sample size, and that will not allow us to do a subgroup analysis. So again, the in-depth, there are 6 types of AACC. So here we do not know, when you read this article, what type of AACC we are talking about. So what data that author has chosen for, this particular patients when they choose to do a PAT and operate them. So I think that data we need to really look for. So that's why the subgroup analysis, which is very aptly the author has mentioned in their limitation, that is the reason why, because of the small sample size, they couldn't do the subgroup analysis. Then another thing is, as far as the sample size, how that has been calculated, what was the power of study, that also need to be mentioned in a statistical analysis section. However, for comparison, the pair test or the Wilcoxon sign test, which has been used, that is very much appropriate for the study that has been done. Assignment, the aim was very well defined. Inclusion and exclusion criterias were also very well defined. Assessment, yes, the appropriate statistical analysis being applied for the assessment and comparisons and come to a results. It gives a good primary outcome when it is being done, that is the prism adaptation test in this group of patients, and outcomes are pretty well in terms of motor as well as sensory. Interpretation, BMR or R&R for deviation after PAT test gives a good outcome on a modest follow-up. Again, the 12-month follow-up is, I would say, usually less than 6 months. We call it as a short follow-up.
Sir, sorry to interrupt. Sir, actually, this is a thesis article, and so the duration was for 1 year. So, in 1 year, we had to complete this study. So, that is why the sample size is less, and that is why the duration is also less.
So that is fine. That is fine. Most of
Yes,
the
sir.
even all prospective or even retrospective studies we see, we do have this. That's why I said this is a modest follow-up period, 12 months, which is pretty good. It's a prospective trial. But what I am trying to tell here is that, if you have a long follow-up, because I'm seeing these patients usually have a tendency to go in a exodrip in long term, especially when you do overdose, because the pat is ultimately it end up with giving you a overdose for the standard surgical dose, right? That is why we don't want undercorrection. That's the primary purpose to do the pat test and get it done. Because if you see the six types of AACC, apart from type 1 and type 2, we know that type 1 is a kind of a sensory variety. Type 2 is, they are kind of emetrope or a low hyperope or a moderate hyperope, right? So if you exclude these, rest of the three entities like cyclical, neurological, and the type 3 Belchowski, in all these we anticipate undercorrection. So if we do a PAT test and get actual, the amount of deviation, so we usually call, if you don't do a PAT test, do the surgery for maximum documented deviation, right? So in that context, if you exclude these first two types, then probably there is a very less chance of exotip. But first two type, you need to keep this in mind as far as long term of follow-up is concerned. Extrapolation, this test can be very well adapted in practice, considering both the Indian as well as the Western cohort that has been experienced or published in the literature, especially in cyclic, neurological, and type 3, which I was just talking about. However, we need to be careful. So I'll take the PAT test, considering PAT test and applying in my own practice with a little bit pinch of salt for type 1 and type 2 AAC. That's what I would do, the Mary analysis, when I see any new article that comes up in a literature. Because you need to understand, we are, every surgeon, for that matter, every practitioner is practicing in his own world with his own understanding and concept. So when you want to change your practice, you need to be critical. Thank you.
Thank you, Dr. Varkat, for giving us that excellent introduction to the MARI analysis. And I'm sure this acronym is going to be very useful for the PGs. It will be very good for them to remember this acronym and use it whenever they are analyzing a journal article. So thank you so much.
Please.
With that, I now request Dr. Krishna Prasad, sir, for his inputs and comments. Sir, we can't hear you.
You're not audible,
Sir, you're not audible.
Dr. KP sir. You're not audible. No, not yet. I think your volume might be at
He's not muted. Sir is not muted, but
muted. Yeah, he's not
yeah,
muted.
but
That's
we
what we
can't
want.
hear him. I think his. Let me call him. Tushar, could you please call Dr. Krishna Prasad? Can't hear. Can't hear. Okay, so Tushar, are you there? If you could just call up and find out what's the problem. No. Okay, so now I request Dr. Akansha Raghuvanshi to just wrap up this, journal article. If you could just add a few parting comments, why you chose this article and anything that you'd like to highlight in this, or any pointers for the PGs. Over to you.
So, with this article, the highlighting point is that in the cases of acute acquired comitant esotropias, so if we perform PAT test, that is the prism adaptation test, so it gives the maximum deviation, and that is very useful in the cases in which we don't like it is very useful for performing the surgeries and for the better outcomes so
ಮಾತಾಡಿ
that the
ಕೇಳಿಸ್ತಾ ಇಲ್ಲ ನನಗೆ.
hello.
Yeah,
Can you
sir,
hear me now?
Yes,
yeah.
we can
We
hear
Oh,
come
you.
okay.
back to you,
Then
Dr.
okay.
Akansha.
Oh, please continue. Please continue.
Okay.
So
Dr.
for the
Akansha, continue.
for the better outcomes and for the better stereopsis results, so this prism adaptation test is very useful, though this can be incorporated in day-to-day practice in such patients. That is the
Thank
main aim we presented this article. Thank you so much.
thank you. Thank you so much. Yes, sir, Dr. Krishna
Can I
Prasad,
just chip
sir.
in last 2 minutes? Thank you, I mean, for bearing with me. I think Dr. Vivek said it very rightly. I think the right way to actually, present an article or even to do a research in terms of a thesis, which is a mandatory for post graduation, is to very objectively analyze your work. It's our baby. Our article is always good for us. Our results are always great. But you should have that objectivity. Like, for example, when you take a particular inclusion criteria, you should also know that there are some limitations. You said it is less than 30 prism diopters you are taking.
Yes,
But
sir.
as I think Dr. Vivek will agree that we have even a very large angle, most of them are more than 30. So
Yeah.
a huge cohort of AACs actually fall out of this particular thing, which may not represent the representative sample of the things that we see in our OPD every day. So it may present a very small cohort, which is usually not representative. So you should be able to, even though you have done this study, you should be able to acknowledge that this is not the usual representation. So we do
Yes, sir.
think that this can happen, maybe with larger. At the same time, you also had said that there are no resurgeries. Obviously, you've already done bimedial recessions or R&R for this less than 30, which is just enough. So the very high possibility of exodrift in most of these cases, even though it is a thesis requirement that it should be done for 3 months. It would have been very nice to tell us that since you have after the thesis also you can continue, the patients keep coming. You would have probably told at 3 months it is like this, everybody was fine, but at the end of 1 year, these patients went for an exodrift. And also it will be a very good idea to understand what made them to go for an exodrift. That would be a better kind of a research outcome that will answer many questions for us. See, the whole purpose of doing a research as a postgraduate or even as a consultant for that matter is to solve some of the problems in our clinical practice. We have some research questions like how to treat an acute concomitant esotropia is a very big question that nobody has solved this mystery. So more and more data coming from you, like a lot of good work from you, having so many patients, having 40 patients is pretty good number. So some input that can really help our practice. Like after, even though they were all aligned at 3 months, at 1 year, so many percentage of patient went for an exodrift can be a warning sign for us to actually really, modulate or modify this particular, or customize this particular thing. And as he said, it's the subtypes are more important. Not one size doesn't fit all of them. So we need to customize in our strabismology. And having said that, most of these patients who actually go for an acute concomitant esotropia have basically a very poor fusional background. Their foundation of fusion is very less. That's the reason why they actually kind of, they decompensate later in life. Even though they're aligned in the initial part of their life, at some point they decompensate. Sometimes refractive errors work, stress works, and so many other things. So that only says that there is an underlying poor, some kind of a binocular foundation. These patients are at the risk of developing an exo, even though you align them with surgically. So this is the whole idea. So having no resurgeries or most of them having, and the 3 months is probably a very short time to really assess the sensory outcome also. Motor outcome, yes, will always change. Even the sensory outcome will change with time. But having said that, every study, good or bad, half are complete. will always say something. At the same time, you should also be able to tell the limitations and say how you could have done this differently. Or if you have the data of a longer follow-up, it would be very nice for you to actually accept. As he said, the message should not go that all these patients, you do a PAT and change your surgery as per the PAT results may not be the right kind of a message to go across. Every message that we give in the research has to be always having some element of this kind of rationality and at the same time some objectivity. No study is perfect and nothing works, and we cannot really call it very dogmatical. But having said that, this is a very good presentation, an excellent thing, and maybe I would be very happy to understand what happened to these patients at the end of 6 months or 1 year. That would be a very good, information for us to actually kind of extrapolate to our practice.
So we will
But
definitely keep these patients in follow-up and
sure,
assess
sure.
that.
And at the same time, for people who are starting strabismology, a prism adaptation test, this would be a very good energizer for them to really put them into practice. And PAT has many applications apart from this. So this would be a very good kind of a boost for those people who want to try this out in their practices, even as postgraduates, so that they get the some kind of an insight how this can actually, because prism adaptation basically simulates a surgically. So patient when they're aligned with prisms, so how does the sensory system behave is a very good idea to understand what they do after surgery. But excellent effort. Uh, Definitely, I do appreciate your the sincere effort for presenting this, and ARC for the entire opportunity for you as well as for us to this occasion.
Thank you so much, sir. Thank you for those insightful comments.
Thank you so much, sir, for your
And
inputs.
yeah, thank you, Dr. Purvan. Thank you, Dr. Akansha,
Thank you.
for that very thought, gave us a lot of food for thought, that presentation. So thank you so much. So with that, we'll move on to the next presenter, and that is Dr. Ria Utpal Majumdar. Dr. Ria is a fellow in the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at the Shankar Nethralaya, Kolkata. And she has been mentored by Dr. Stuti Somani Agarwal, who is an associate consultant in the Pediatric Ophthalmology Services at Shankar Nethralaya, Kolkata. So, looking forward to your presentation. Dr. Ria Utpal would be presenting on a very interesting topic that I think we all want to know more about, in today's times, and that is long-term myopia control, effect and safety in children wearing DIMS spectacle lenses for 6 years. So, Dr. Ria, looking forward to your presentation on this DIMS glasses.
Okay. Are my slides visible?
They're
Yes.
visible, Dr. Ria.
Good evening, everyone. So first of all, I would like to thank AIOS ARC for giving me the opportunity to be a part of this prestigious platform. Today, I'll be discussing about the role of defocus incorporated multiple segment, that is DIMS glasses, in the management of myopia. So why are we concerned about myopia in the first place? Myopia has become a global epidemic in the recent decade and is estimated to involve almost half of the global population by 2050. Of this, 10 to 20% are estimated to have high myopia, which is associated with ocular complications such as cataract, glaucoma, retinal detachment, and maculopathy. And these are all causes of irreversible vision loss. Thus, there is an urgent need for for aggressive treatment of myopia, both in terms of correction of spherical error using glasses and preventing further myopia progression. So here we'll be discussing specifically about peripheral defocus glasses, which gives us a dual advantage of both myopia correction and myopia control. So the study I'll be discussing today was a Hong Kong-based study by Lam CS published in Scientific Reports in 2023. So the group evaluated the long-term myopia control effect and safety in children
wearing DIMS glasses for a study period of 6 years. So before we move on to the main article, I would like to discuss two concepts that will help us understand this article better. So the first concept is that of peripheral defocus theory. So what is peripheral defocus? The normal eye is a spheroid structure. So in myopia, there is axial elongation along the central visual axis, which gives the eye a more oblong shape. So as we can see in the first diagram here, the central light rays continue to fall in front of the fovea in myopic patients, while the peripheral light rays get focused beyond the retina here. So this gives a relative hyperopic defocus, which acts as a stimulus for further increase in the axial length and increases myopic refractive error in these children. So peripheral defocus glasses try to convert this zone of hyperopic defocus into a relative myopic defocus so that they can get rid of this stimulus for further myopia progression. So based on this concept, we have the defocus incorporated multiple segment or DIMS glasses. These glasses have a central zone of 9 millimeters in diameter for distance refractive correction. It is surrounded by a 33 millimeter diameter of an array of multiple segments, each segment with plus 3.5 diopters myopic defocus. So now that we have understood how DIMS works, let us see what the article tried to compare. So first of all, the study group included Hong Kong-based Chinese children who were aged 8 to 13 years with spherical errors of -1 to -5 diopters, astigmatism or anisometropia of less than equal to 1.5 diopters, and a monocular best corrected visual acuity of logMAR 0 or 6/6. For the purposes of the study, only right eyes of the study subjects were included. Children with strabismus and binocular vision abnormalities and those with ocular and systemic comorbidities were excluded from the study. So Dr. Lam and her group studied these children for an initial period of 2 years, then followed them up for a third year, and these same children were evaluated for long-term outcomes over a study period of 6 years to study the efficacy and safety profile of DIMS glasses. So in the initial part of the study, that was the 2-year follow-up study, they compared children wearing DIMS glasses versus children wearing single vision glasses. They found that myopia progression was reduced by 52% and axial elongation was reduced by 62% in children wearing DIMS glasses. And DIMS had the greatest effect within the first 6 months of wear, which was sustained to the entire 2-year study period. For the third year of follow-up, they shifted the children wearing single vision glasses to DIMS glasses and included a separate control group for comparison of the results. So what they found was, in the DIMS group, the same amount of myopic progression and axial length change was noted. However, in the control to DIMS group, there was a decrease in the axial length elongation and the change in spherical equivalent with the use of DIMS. Now coming to the main article that we'll be discussing today, these same children were followed up to 6 years. The main objectives of this article were to monitor the changes in spherical equivalent and axial length over the study period of 6 years, to evaluate the safety of these glasses, and to look for any rebound effect after discontinuation of the DIMS glasses. Now, these children, after the third year of follow-up, were further evaluated for 6 months, after which there was a period of discontinuity within the study due to the COVID pandemic. So the patients had to be released from the study at 3.5 years, but they were recalled at 6 years for assessing the changes in spherical equivalent and axial length. So depending on the type of glasses that the children wore during this period, they were classified into 4 groups. So group 1 included 36 children who wore DIMS glasses throughout the entire study period, which included the period during which they were lost to follow-up. Group 2 included 14 children who wore DIMS glasses from 0 to 3.5 years, but changed to the single vision glasses during the pandemic years. Group 3 had 22 children who wore single vision glasses from 0 to 2 years. They were switched to the DIMS glasses by the investigators for the third year follow-up study, but they continued to wear the DIMS glasses throughout the rest of the study period. Group 4 had 18 patients who wore single vision glasses in the initial part of the study for 2 years. They were switched to DIMS glasses by the investigators at 2 years, but they discontinued DIMS glasses after 1.5 years and switched to single vision glasses during the pandemic years. So as we can see from this figure, the blue line here, the blue solid line here shows group 1 who continued wearing DIMS, and group 3 here showed the children who wore DIMS, who were shifted to DIMS from single vision glasses at 24 months. So these group 1 and group 3 were the children who were wearing DIMS glasses at 6 years recall. Group 2, that is the green dotted line here, and group 4, that is the black dotted line here, these two groups were the groups who were wearing single vision glasses at the end of 6 years. So now that we have our groups, let us see how each group performed in the study period. So in group 1, we can see there's a sustained effect of the DIMS glasses throughout the 6-year period, thus showing a reduction in myopia progression in these children. In group 3, that is the red graph here, the initial 2 years, they were wearing single vision glasses, which showed myopia progression throughout this study period. They were shifted to DIMS at 2 years, which had a stabilizing effect on the myopia progression. In group 2, they were wearing DIMS glasses for the initial 42 months into the study, but shifted to single vision glasses during the pandemic years. So there was a steady increase in the spherical equivalent as well as the axial length. Thus, there was myopia progression in this group. In group 4, they were wearing single vision glasses for the initial part of the study. They were switched to DIMS in between, which had a stabilizing effect on myopia progression. But then they discontinued DIMS and switched back to single vision glasses, which again shows a myopia progression during the later part of the study. Thus, group 2 and group 4 had progression of myopia after they switched from the DIMS glasses to the single vision glasses. So the authors also pointed out an interesting observation at this point. If we look very carefully at the group 4 graph here, so in the initial part of the study, they were wearing single vision glasses and we notice a myopia progression. And after discontinuation of DIMS, they have shifted to the single vision glasses and we again notice a myopia progression. And the slope of this latter part of the study is almost similar to the initial part of the study prior to wearing DIMS. So the authors concluded that there is no rebound effect of discontinuation of DIMS. So now that we have seen the children, followed up these children over the entire 6-year period, let us focus only on the loss of follow-up period between 42 to 72 months. So here the authors found an interesting thing. That was group 1 was wearing DIMS throughout the entire study period, while group 3 were initiated on DIMS after 2 years of wearing single vision glasses. They found that myopia progression was slower in group 3 as compared to group 1. So they concluded that DIMS works better in older children. Also, in group 2 and group 4, who were wearing single vision glasses, they found a higher myopia progression as compared to groups 1 and 3, who were wearing DIMS glasses. At this point, they have also introduced the concept of relative peripheral refraction and stated that more the amount of hyperopic defocus in these children, better is the effect of DIMS in these study subjects. So this may affect to some extent the changes in spherical equivalent and axial length that we note in group 1 and group 3. So the authors have compared their results with other optical myopia management modalities and found that DIMS glasses are much better in terms of axial length and spherical equivalent change as compared to executive and prismatic bifocals, orthokeratology, and multifocal soft contact lenses. The only other randomized control trial that evaluated any myopia management modality over 6 years was by a UK-based group led by Chamberlain P. in 2022, who studied the effects of dual focus contact lenses over a period of 6 years. So the authors have compared their findings with the findings of the study by Chamberlain P. and found that there is not a significant difference between the results of the two studies. So they concluded that both these modalities have equal efficacy in terms of myopia progression. So let's have a look at other similar studies conducted related to outcomes of DIMS in myopia management. So Dr. Shruti in 2024 conducted a similar study amongst Indian children who were aged 7 to 17 years with spherical error of -1 to -9 diopters over a study period of 18 months. So they concluded that 32% of these children had no spherical equivalent progression and 94% had progression less than -0.5 diopters in the DIMS group, which corresponded to findings in our study. Another German-based group led by Neller B. et al. In 2024 studied European children for evaluating the effects of DIMS glasses in myopia. So they divided the study sample into different groups based on the degree of myopia and age of the study subjects. They concluded that moderate baseline axial lengths responded better than high baseline axial lengths. Thus, high myopes and younger age of presentation require additional management over and above the DIMS glasses. Nuki P. in 2023 compared DIMS glasses with low-dose atropine and a combination of the two modalities and found that the combination therapy had a much higher response than monotherapy with either LDA or DIMS. Dr. Chethani in 2024 evaluated DIMS glasses in children refractory to low-dose atropine. He found a response in 8 out of 10 children and thus concluded that DIMS can be used as a supplement to the low-dose atropine in refractory myopia. Ruech et al. In 2021 evaluated headache and eye strain in response to peripheral T-focus and loss in contrast sensitivity due to these glasses, but did not find any significant symptoms in either adolescents or adults. However, in contrast to this study, a study that was conducted by our very own Shankar Nethralaya in Chennai in 2024 had a quality of life study which evaluated patients on the basis of physical and psychological domains. They found that headache and eye strain were frequent complaints in these patients, but their patients did well on other physical and psychological domains. Quality, affordability, and accessibility, however, continue to remain major concerns with these glasses. So the main strengths of my study were, it was a prospective study with a long-term follow-up. The authors were able to compare with other optical myopia control modalities, and the results could be extrapolated to the general population. The main limitation of the study was the presence of selection bias, as the patients self-selected their choice of glasses during the study period, especially during 42 to 72 months during the COVID pandemic. So there was no randomization amongst the study subjects. Because of the loss of follow-up during the pandemic, there was a high attrition rate and a high dropout rate amongst the study subjects. The pandemic showed a massive shift in behavioral patterns, such as increased screen time and decreased outdoor activities, which are established factors for myopia progression. So these were confounding variables for the later part of the study. The authors estimated the rebound effect by comparing changes in spherical equivalent and axial length prior to wearing DIMS and after discontinuation of DIMS as we saw in the graphs for group 4. However, if we have to calculate rebound effect, it should ideally be calculated by comparison against age and spherical equivalent matched new patients who have not been put on any myopia interventions. So this was not an accurate measure of rebound effect. So my main take-home points from the entire presentation would be, DIMS is a reliable option for myopia control in low to moderate baseline myopia, especially in older children. It has a sustained effect with no rebound effects. It is a safe option, even though it is associated with subjective symptoms like eye strain and headache. Affordability, accessibility, and availability continue to remain main concerns with these glasses. Thank you.
Thank you, Dr. Ria, for that very, very well-rounded exposition of the subject. So you really went into the depths of the subject and presented very well. Thank you so much. So with that, I request Dr. Krishna Prasad, sir, for his insights and comments on this.
Okay, just a question, okay, Dr. Ria, this particular study, okay, had to make some changes, some U-turns because of the COVID pandemic, right?
Yes, sir.
So what was the basic plan? Like if there was no pandemic, what would have been there actually the way the study would have gone?
So they wanted to study these subjects up to the 6 years and see if there are any sustained long-term side effects or
How many
safety.
groups are there in the beginning, like in the
So,
original plan?
So in the original plan, there were 3 groups. Like the third year follow-up study they had done. So they have one group that was wearing DIMS throughout. The second group had shifted the subjects from single vision to DIMS, and they had a control group who had not been started on any myopia interventions as of yet. So they were planning to compare the 3 groups.
So,
But then,
so there is some good in every bad thing, they say. So this particular turn of events, how actually it benefited the study? I mean, do you think any good thing coming out of this particular change of plan? Like,
so they were able to evaluate if there is any rebound effects, and they were also able to evaluate that, for example, in group 4, the patients were wearing single vision, then they shifted to DIMS and then back to single vision glasses. But we did not see a spike in the myopia progression after they discontinued the DIMS. It was not an uncontrolled myopia progression in these subjects. So
the thing that we see, even Dr. Vivek will agree, the COVID pandemic has created such an amount of change in the psychosocial and behavioral pattern of children. Okay, there is a complete, upturning. So it has completely changed the whole scene. Okay, so this particular change in the behavioral pattern, would it not be a major confounding factor that we continue to study the same thing because this started before COVID, went through COVID actually. So
yes.
don't you think that's a confounding factor?
Yes, sir,
Apart
it
from the
was.
good, this
That
is
is
the
why.
bad.
Yes, sir, it was. That is why I wrote it as a limitation. So it was a confounding variable
And
for
the
the
title
study.
says the safety of the study. Look, basically, what do you actually mean by the safety? What exactly you would like to actually discuss in terms of the safety of DIMS classes? Effectivity, fine. You talked about it. Say effectivity and safety are the two concerns, right? So let's
Yes.
talk about the safety. Can you really expand on this particular safety of DIMS classes? What exactly you mean by safe or unsafe?
For instance, if there are any, the authors have evaluated stereo acuity, then phoria, and objective measures such as monocular or binocular amplitude of accommodation in these subjects. If there are any changes in these factors, so they did not find any significant changes. So that is how they concluded that these glasses are otherwise safe overall.
Sir, if I may just add a point,
Yeah, please.
since low-dose atropine is the most common modality that we are using, with which we know that there is chances of photophobia, or maybe the amplitude of accommodation goes down, there may be near vision problem. So maybe the secondary outcome from this paper, which they studies, was the visual function. And they have specifically maintained about the visual acuity distance near, any component of phoria for near especially, and the amplitude of accommodation. So that is where they are talking about the safety profile of DIMS. That is it affecting any visual functional pathway as such? I mean the parameter as such.
Oh, that's exactly. So it's the visual performance, basically,
Correct.
either in terms of visual fields or in terms of stereo acuity, in terms of. So, what was the parameter that they study to analyze the safety? That's what I was asking.
Yes, sir. So they have taken the visual acuity, distance near, they have studied the phoria and the amplitude of accommodation, stereopsis, 4 parameters.
Okay. So, but there was no atropine in this study. It was only about
No, no,
DIMS.
no, no, no.
No.
It
Yes,
was
sir.
not
I
about
think
it.
during the discussion somewhere they have just mentioned it about that the low dose atropine has caused this problem. So they have checked the visual function parameters, comparing it with atropine. So initially they had started with DIMS and single vision glasses. With all the pandemic, they subsequently had 4 groups. Now, even if she can go back to her previous slide, so
Yes,
this was
just a
not a
second.
planned thing. If you can just show that graph which we were discussing, where we have, so they started with DIMS and single vision glasses. So there are two
Just a second.
groups. Yeah, if you can go back.
Um,
Actually, this is a very interesting
so
study. Actually, this needs a real deeper probing because there is so much
When
that to
we were
mine out of this.
discussing, yes,
There is
sir,
so much of extrapolation that we can do. I think
I
Dr.
agree
Vivek can also
absolutely.
agree with me and can probably contribute because
Yeah.
it really requires a very detailed, because this particular turn of events has created so much possibility to mine so much of information
Yes.
uh, from this.
So if
just
you
a
Yes.
can
second, sir.
just go back to that slide where we have the first graph about the change in spherical equivalent and the axial length elongation.
Yeah, just a second. Yeah.
So even here, if we see the group 3 and 4 who had actually
Yeah.
started off with single vision glasses. So if they are wearing single vision glasses, they should have had the same rate of progression. But for first 6 months, there is similarity. Thereafter, there is a distinct disparity between the way the two graphs are moving. So maybe there is some underlying factor which they have not considered or maybe not investigated, which is causing for the change. So subsequent effect of DIMS and the sustained effect, probably even after stopping DIMS, it's a little unreliable over here. We do not have a good value over here. So they haven't highlighted. They themselves have shown that group 3 and group 4, there is a mismatch, but they can't explain the mismatch. So that is one point from the paper that I would like to highlight.
Yeah, very well brought out.
So
So, Dr. Varkat, if you would have any inputs.
yeah, so I think first of all, I would like to really congratulate the RIA, because this article is very complicated. If you look at the methodology, and she has very nicely, make it so simple. Believe me, I read this article 2 times, and even the half hour before, I was still trying to understand, how they have had, the initial study. They started with a different intention, and then they went on, like probably heavy, but they don't want to, they want to utilize their data, because it's been like 6 years, right? So it's very valuable data. So they have created 4 groups, which she has very nicely mentioned. The first group from day 1 to 6 years, right? Then six,
Yes.
and then the second and third group. So if I would want to summarize, probably the group 1 and 3 who were actually on DIMS, isn't it? And group
Yes.
2 and group 4, they discontinued the DIMS. Right. So
Right.
one interesting thing that is coming out of analysis, that the group 1 and 3, they have shown a good myopia control, or a less progression. That is what you can take home from this particular study. And the group 2 and 4, they have shown a faster myopia progression. So if I would want to be in a group 1 and 3. That is one thing, one aspect. Second aspect of the overall study, which Ria has highlighted, what are the limitations? What I personally felt, there are a lot of things which they didn't mention, as far as stats is concerned, like how they have tried to understand, the cumulative progression and reduction in the risk of myopia control. what method that they have used, they didn't mention. They have mentioned they analyze only the right eye. Why not the left eye? So that data is also is not coming into this. Another point which makes me understand, or my interpretation is, I think this is very good, which is coming out, that these myopia glasses or a DIMS glasses, they are more effective in older children than the younger one. So this is probably I would add in my practice. If I want, I do a open field auto ref, and I find that there is a hyperopic defocus of this elder age group. I would choose that as a first choice, because this is a huge valuable data over a period of 6 years. Rather than I'll put them on, as a convention, what right now we are using is a low dose atropine. That is one thing. Second thing is, for a younger age, my choice would be LDA. But when they are not responding, I would always choose to add again the DIMS. Right. So I think this is something new thing which is coming up out of this paper. Then the long-term use of DIMS, as we were discussing, there are no adverse events. So I don't need to worry. I can counsel my patients. You don't need to worry, at least for 6 years, you'll not have any visual system related side effect, which Stuti has just now mentioned. So we can assure to our patient. Another thing is, the study become by convention the first to look for the rebound after discontinuation of the myopia control over 2 to 2.5 years, right? So I think by convention this is something coming out good, out of what the doctor KP sir was saying, what the bad and good. So this is something good, because by convention we understood that such a 2.5 year long-term follow-up for these DIMS. We know about the atropine. There is a lot of literature on that. But what happens to the DIMS if somebody would discontinue? So then it's a very good kind of, the resisting the rebound effect. So they are the probably choice if I want to add on therapy as per what, the Jitendra has published. So it's a very good article, and I would not really I don't have anything to take with pinch of salt for this particular study. Thank you.
If I can just
Thank you.
add to
Thank you,
what
Dr. Bhatta.
Dr. Vivek has just said. So DIMS is an expensive affair, and like he rightly said, you can't be changing glasses very frequently. So if we can just look for our practice, if we can just look at the lag of accommodation by doing a dynamic retinoscopy, and this same study group, when they've done their 2 years and 3 years follow-up, they have highlighted if there is young age of the child with myopia and parental history of myopia, they have a peripheral myopic refraction. For them, DIMS does not work. Now, with age, when there is axial elongation, probably the retina becomes a little more oblong. So it becomes conical. And then with time, there is hyperopic defocus which comes in. So that is why probably this study also, they have highlighted that once they changed, like the group 3, when they started wearing DIMS glasses after the change of the glasses after the initial period, that is, they started DIMS later, those kids had a sustained effect rather than those kids who were already wearing DIMS since day one. So that is two things. I think peripheral refraction, even if we don't have an open field auto ref, we can just do the peripheral refraction, and a lag of accommodation, because lag of accommodation, if it's there, then atropine is not a good choice for them. And these cases, we offer DIMS. So that will be a better option for patients also.
Thank you, Dr. Stuti. We have a quick question. You just said older children. So what is that cutoff age when you say older children?
So
What age
when
group?
this article itself has written, at 8 years is when they see a rapid progression. So less than 8 years, they are seeing a graded progression. After that, DIMS is also very effective. And the reason is the peripheral hyperopic refraction that we are getting, the peripheral hyperopic defocus. So maybe initially, like sir said, LDA is very cheap, ma'am. So we can just start them off on LDA, see the behavioral modifications. And then at a later age, if it is progressing, or even if it is refractory to low-dose atropine, or there is a problem with accommodation, then we switch to DIMS. And Dr. Jethani sir's article on refractory cases where LDA was not working, he has combined the two, but he has a 1-year follow-up on that. So that is also working well. So I think LDA we start, and then how it progresses, maybe by 7, 8 years, we consider using this.
We have another question in our chat box. So these children who were, not followed up during COVID, were they wearing the same glasses, throughout those 2 years, or were they getting refracted and changing their DIMS glasses?
That is the clarity that we don't have. And that is why it is a long-term study, but we still do not have that data for 3.5 to 6 years. So in that ways, we have something about 6 years, but there is a lacuna there.
Okay. So otherwise, in your practice, are you using these glasses?
We are counseling patients. It is expensive. So the ones who can afford it, we are. But I have been doing the LDA plus DIMS. I have not just kept the child at DIMS.
I think we have been, sorry, the only problem with them presently in India is the cost. At the same time, it is not one time. So it's not like a low vision aid that you give it off. So it keeps changing. As the refraction changes, you need to change the central correction. So that be the basic problem. Otherwise, if DIMS were to be more affordable, I think there would have been wider use, there would have been more studies even in India. I think the only problem why we don't have a huge, large studies in India is basically the prohibitive cost. At the same time, the availability in the smaller places. That's the whole idea.
Yes, so Dr. Bali, in our myopia center, we have the open field outdoor refractometer. So we, by baseline, categorize them, subject every patients for the open field outdoor refractometer. So at baseline, if we found that there is a very high hyperopic defocus, then we subject them for, the DIMS glasses. Otherwise, they are like, the low hyperopic or a myopic defocus, then the choice by convention would be, the low dose atropine. However, there are subset of patients when we didn't had open field outdoor refractometer. So by convention, we assume that probably, this is the only mechanism, expansion of scleral fibroblast, where the atropine has a key role, to regis that. So we are assuming that there is the drop as a primary treatment. However, over a period of 1 year, 2 year, we notice that, okay, they are not responding. Then we have added them on the DIMS therapy. And then both together, they actually works. But at the end of day, the take home message is all these modalities, they are to slow down the progression, not to halt the progression. We cannot halt the myopia progression. We are just trying to delay, trying to slow down the myopia progression.
And what is the age till you prescribe these glasses? Till what
Yes.
age does the child wear them?
Age nowadays, if you see the latest literature from Singapore and other part of the world, that cutoff has been increasing. Like 16 years, the 3 to 4 years back we were talking about 14 years. Now there are articles which are talking about like 16, 18 years. However, the very high pathologic myopes, those who are like more than 18 or 20 years, I don't think, I personally do not advise the LDA for this group of patients. And also these glasses, the DIMS, they have the limit, like -20. You can't make DIMS with -20. So there is a range. So you have to prescribe in the available range.
So usually the spherical equivalent needs to be 10. So that also we need to keep in mind. If we let the myopia progress and it goes beyond, then DIMS is no longer an option. So maybe that spherical equivalent we need to keep in mind when we are monitoring these cases.
Thank you.
So, Ria, just to complete the whole discussion, what about the other changes? Like pharmacological as well as glasses are okay. What about the behavioral changes and what advice you give so that it will benefit the postgraduates?
So usually we ask these children to limit their near activities. So first and foremost, screen time. We ask them to decrease their screen time.
Stop reading textbooks.
No, sir. No, sir. We ask them to decrease their near activities. So, and try to increase outdoor activities as much as possible, and to maintain adequate sleeping hours during the night. So, adequate sleep, adequate rest, and decrease in the near activities are the main things that we prescribe.
So is reading versus screen time, like looking into a mobile or an iPad, does it make a difference from reading the book? Because parents need
Uh,
clarity on this, right? They may not allow the
yes.
child to read the textbooks also.
So we usually reading. Usually we cannot ask the child to stop reading, so we ask them to limit the screen times that are held at a more closer distance. So they can be asked to watch the TV or use the laptops for a limited amount of time. But since the mobile phones are held at a closer distance, so the near activity is what causes the myopia progression.
I think the
So,
SCORM study has mentioned about near activity, as in reading, also being a risk factor. And now that we have such so much of academic stressful environment, the competition which is there, and the schools going online and offline, sometimes we just recommend whatever is necessary you need to give. Otherwise, you can just give the printouts, certain things, projects. Now, parents can also help and make, because if the child is progressing, what use is of that project? So that is also one option we give parents, to just take printouts, take frequent breaks, good illumination, and 10 o'clock sleep pattern. That's what we emphasize.
Even technology, a lot of parents are screen mirroring their mobiles onto the TV screens, and their actually child is actually looking at the TV at a much
Correct.
distant place
Correct.
rather than looking into a screen.
Yeah, I think what Dr. KP sir is trying to elude here is that, the environmental change is one of the most and first step of, the management of myopia progression. This AIOC, APO, AIOC, we had a symposium where, we were talking about the risk factors and different management aspect. So Dr. Ken Mitchell and group, they have started a practice in US, particularly in Pittsburgh University. They do develop the agreement with the parents. We will start treating the myopia progression when you are agreeing that you would have or provide environment where the child would follow the lifestyle modification. Otherwise, believe me, all this therapy with uninhibited the use of screen and not following the environmental recommended modification, which are now each and every recommendation is scientific. There is a scientific logic behind this, right? So in that context, I think it is very important to understand, especially when you see any patient at baseline, you have a waiting time of starting them on pharmacological or optical therapy. It is right time to insist or make them understand that the importance of the lifestyle modification. In my practice, I always tell them, even the pre-myopes, low hyperop, I start counseling right away. So by convention, every refractive error, I started counseling them about the lifestyle modification.
Thank you. Thank you so much. I think we've had a wonderful discussion. Thanks to our young presenters, Dr. Purva and Dr. Ria. You were excellent and, gave us stimulus for all these excellent inputs that we've got today. Dr. Akansha and Dr. Stuti, great mentoring. Both the candidates presented very well. And last but not the least, a very big thank you to Dr. KP sir and to Dr. Varkad for all the excellent insights and inputs, and for summing up those articles so wonderfully. I think there was some great knowledge shared today, this evening. And with that, I thank also the audience that has been with us today. And thank you so much. With that, I bid you a very good night. We have a similar episodes coming up every Thursday. So I request all the PGs who are with us tonight to log in again next week and every subsequent Thursday. So thank you once again. Thank you, everyone. And a very good night. Thank you.
Thank you so much. Lots of
thank you.
learning. Thank you, everyone.
Thank you.
Thank you, everyone.
Thanks.